Hi there. This is a brief overview of updated clinical practice guidelines and Joint Commission accreditation standards for pain management that recommend the use of non-pharmacological treatments, either as adjunctive therapies or as standalone treatments. After I go through some of the current evidence-based recommendations, there'll be a survey that should take no more than 8 to 10 minutes. Just to put the opioid crisis into perspective and the importance of being aware of opioid overprescribing, in 2017 there were over 70,000 overdose deaths in the U.S., of which 68% were opioid related. Of the 50,000 opioid overdose deaths, more than half were from prescription opioids. This is an average of 130 overdose deaths a day in the U.S. related to opioids. We need to keep in mind the best solution is to use a multi-pronged approach. Along with using data, such as cures, to target prevention or to identify abuse or fraud, or screening tools to enhance diagnosis of opioid use disorder with expansion of access to treatment, we also need to manage pain using a safe and effective range of treatment options. We can do this by basing treatments on the newest clinical practice guidelines for pain management, as well as adopting and maintaining Joint Commission standards. With this being said, these are guidelines only and must be used with sound clinical judgment. We do not want to undertreat someone's pain either. How often have you had to treat incidental back pain on our hospitalized patients, possibly due to pre-existing conditions or the hospital bed or surgical positioning? This Clinical Practice Guideline, or CPG, from the American College of Physicians discusses some non-invasive treatments for acute, subacute, and chronic low back pain. It was updated in 2017. All reference CPGs will be provided in a link in the survey that follows. Acute or subacute low back pain has been demonstrated to improve over time regardless of treatment. Thus, the initial treatments of choice by clinicians and patients should be superficial heat, massage, acupuncture, or spinal manipulation. If further relief is required, non-steroidal anti-inflammatory medications or muscle relaxants should be used. Noted results of systematic reviews that the CPG was based on were that massage and heat provided moderate pain relief, whereas other treatments had minimal to small pain relief. Acupuncture demonstrated a small improvement in pain over NSAIDs, as did heat over simple analgesics. Chronic low back pain exacerbations should be treated with exercise, such as providing physical therapy involvement, or multidisciplinary rehabilitation, which involves physical treatments such as heat, electrotherapeutic treatments by pain management, stretching or strengthening with PT or OT, manual therapy by an osteopath or massage therapist, and a psychological component, such as guided imagery, and of course, physician management. Other treatment recommendations include acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercises, progressive relaxation, biofeedback, low-level laser therapy, cognitive behavioral therapy, or spinal manipulation. Again, noted results of systematic reviews were that motor control exercise, progressive relaxation, biofeedback, cognitive behavioral therapy, multidisciplinary rehabilitation, and acupuncture all provided moderate pain relief, whereas other treatments demonstrated minimal to small pain relief. Tai Chi also provided moderate pain relief. If further relief is required for patients with chronic low back pain, then clinicians and patients should consider NSAIDs as first-line therapy, then tramadol or duloxetine as second-line therapy. Other opioids should be considered if benefits outweigh the risks for individualized patient cases. For example, a low score on the opioid risk tool or personalized discussion with the patient on known risks and realistic benefits. One needs to keep in mind that these recommendations are geared towards the opiate-naive patient. Patients on chronic opioid therapy are not included in this discussion. The most recent CPG on postoperative pain management from the American Pain Society is from 2016. It is based on systematic reviews and was reviewed by an expert multidisciplinary panel. Recommendations in this CPG stress the importance of preoperative education and perioperative pain management, which has been associated with reduced postoperative opioid consumption. It also points out that the preoperative evaluation should include medical and psychiatric comorbidities, medications, history of chronic pain, substance abuse, and prior postoperative treatment regimes and responses to guide the pain management plan. The pain management plan should be based on evidence regarding specific surgery, but also must be individualized according to unique patient factors. This CPG also strongly recommends the use of multimodal therapies to include non-pharmacological treatments with a variety of analgesic medications. Clinicians are encouraged to consider use of around-the-clock non-opioid analgesics and non-pharmacologic treatments to be included in the multimodal regimen. Suggested treatments include cognitive behavioral therapy and TENS for surgeries such as thoracotomy, open laparotomy, joint replacement, cesarean section, CABG, and spinal fusion. Due to variability in effectiveness, the panel could neither recommend nor discourage acupuncture, massage, cold therapy, localized heat, continuous passive motion. However, they noted these therapies are considered safe. The panel does recommend TENS therapy to be included for postoperative multimodal pain management. Cognitive behavioral modalities recommended as part of a multimodal pain management regime include guided imagery and other relaxation methods, hypnosis, and positive intraoperative suggestions. Music is considered part of a multi-component relaxation technique or can be a separate intervention. Cognitive behavioral modalities can be provided by a variety of practitioners, psychologists, nurses, physicians, and social workers. We are often called upon to treat patients with a history of chronic pain when admitted for another condition. We have the potential to impact future opioid requirements if we introduce these non-pharmacologic treatments for pain management during their inpatient stay. In response to the U.S. opioid crisis, the Department of Health and Human Services is focused on preventing opioid use disorder and providing more evidence-based, non-pharmacologic treatment options for chronic pain. This evidence summary is the result of the multi-agency collaboration. Treatments that were associated with either improved function or improved pain included: for chronic low back pain, exercise, including physical therapy, psychological therapy, low-level laser therapy, spinal manipulation, massage, mindful-based stress reduction or MBSR, yoga, acupuncture, and multidisciplinary rehabilitation. For chronic neck pain, low-level laser therapy was recommended. Chronic knee osteoarthritis, exercise, including physical therapy, ultrasound, electromagnetic field therapy, and acupuncture. Exercise, including physical therapy, was the treatment recommended for chronic hip osteoarthritis. Fibromyalgia treatments included exercise, cognitive behavioral therapy, myofascial release therapy, Qigong and Tai Chi, acupuncture, and multidisciplinary rehabilitation. For chronic tension headaches, the recommendation are spinal manipulation, laser, and acupuncture. The Consortium Pain Task Force recommends evidence-based non-pharmacologic pain therapies as part of comprehensive pain care for patients with acute, chronic, and/or cancer pain. These non-pharmacologic treatments have been shown to reduce the need for opioids to manage post-surgical and acute pain, reducing the risk of progression to chronic opioid use. They have been shown to reduce pain while also reducing anxiety and depression, nausea, vomiting, facilitating restful sleep, and increasing a patient's sense of well-being and desire to participate in their own recovery. They've also been shown to not only reduce chronic pain, but to improve function with benefits lasting well beyond intervention periods. Recommendations by the Pain Task Force embrace non-pharmacologic modalities to be used as standalone interventions or in combination with medications, procedures, or surgery. They also support inpatient access to effective non-pharmacologic therapy options including acupuncture, massage, mind-body interventions, music therapy, and TENS use. Additionally, referral to a course of effective non-pharmacologic care when discharged from inpatient for acute, subacute, chronic, and cancer pain should be part of the comprehensive pain plan. Evidence-based options include acupuncture, chiropractic, and osteopathic manipulation, massage, physical therapy, mind-body therapy such as mindful-based stress reduction and cognitive behavioral therapy, and movement therapies such as yoga and Tai Chi in addition to exercise. As of January 2018, Joint Commission accreditation standards have 18 updated elements of performance for pain assessment and management in the acute care facility that must be met. This project focused solely on element of performance number 2. The hospital provides non-pharmacologic pain treatment modalities. The rationale provided by the Joint Commission is that although some evidence on the various treatments is limited or mixed, they can still be used as complementary methods to potentially reduce opioid medication requirements for some patients. Recommendations of therapies to be considered after individualized discussions with patients, taking into consideration preferences and safe practices are physical modalities such as osteopathic or chiropractic manipulation, acupuncture, massage, or physical therapy, relaxation therapy such as music, guided imagery, distraction, and cognitive behavioral therapy. The Joint Commission stresses acceptable non-pharmacologic treatments are not limited to these. Non-pharmacological pain management is one approach to a comprehensive method of pain relief. They do not replace pharmacological methods of pain management and can be used in conjunction with pharmacological pain practices to enhance the patient's relief of pain. Non-pharmacological pain management therapies can be classified into 3 categories. There are cognitive or behavioral strategies, which include distraction, relaxation, imagery, and breathing techniques. The second category is physical or cutaneous strategies, which include heat or cold, vibration, massage, position changes, and transelectric nerve stimulation or TENS unit. Finally, there are environmental or emotional strategies such as touch, reassurance, or the environment of the room or surroundings. And finally, why are non-pharmacologic treatments important in relationship to the opioid crisis? Studies on multimodal pain management regimes have frequently shown improved pain control while minimizing the use of opioid medications. Studies show improved patient satisfaction, and they empower patients to actively participate in their healthcare journey. They have an economic impact in that they lower future healthcare utilization, as well as through a reduction of productive loss for employers as a result of engaging in healthier lifestyle choices, benefiting the whole person in addition to a targeted disease or condition. Finally, I want to sincerely thank you for your time. I truly appreciate it.